The use of cognitive behavioral therapy in the treatment of social anxiety disorder. A presentation brought to you by Barbara Milmine, Krystyna Namolovan, and Loyce Oduor. Social anxiety disorder, also called social phobia, is an intense and persistent fear of being scrutinized and judged by others, and it seriously impacts individuals' everyday activities. People with social anxiety have persistent negative thoughts and exaggerated perception of social threat without any valid reasons. This presentation will provide the background and description of the disorder and will discuss different cognitive behavioral therapy treatment processes used in the treatment of social phobia.
Let's start by examining what social anxiety disorder is, how it presents, and how it can affect people's lives. Individuals suffering from social anxiety disorder have a fear or anxiety of being embarrassed, humiliated, or shamed in social situations. The social situations that trigger anxiety can fall under either situations that involve interpersonal interactions or situations that involve performance-related scenarios. Examples of situations that involve interpersonal interactions include meeting new people, dating, or talking on the phone. In this type of presentation, even ordering food at a restaurant or returning an item for a refund at a store can cause severe anxiety. Examples of triggering performance situations can include public speaking, participating in meetings or classes, and may even extend to activities such as using public washrooms or eating in front of others. In the face of feared social situations, people with social anxiety disorder may experience dysfunctional effects to their thoughts, feelings, and behaviors. Social anxiety disorder is one of the most widespread anxiety disorders and is among the most common psychiatric illnesses. Prevalence rates across North America are quite consistent, with 12-month rates at around 7% and slightly higher lifetime prevalence rates. Global prevalence rates tend to be quite a bit lower on average, with 12-month rates ranging between 0.5 and 2%. The lowest rates of occurrence are seen in Asian countries and are reflective of cultural factors, which we will discuss further in a few minutes. Symptoms of social anxiety disorder usually begin to appear prior to age 18, and onset may follow a stressful or humiliating experience such as being bullied or vomiting in public. Social anxiety disorder appears to be more common in women than in men. While the 12-month prevalence rates in children and adolescents are comparable to those in adults, these rates decrease with age. The 12-month rates for older adults in North America range from 2 to 5%. The DSM-5 lists 9 criteria used to diagnose social anxiety disorder. Importantly, the triggering social situations must almost always provoke fear or anxiety, and the person must have some awareness of the excessive or unreasonable nature of her social fears. This helps to distinguish social anxiety disorder from other diagnoses or from neurotypical shyness or anxiety. If the social situations cannot be avoided, they are endured with intense fear or anxiety to a degree that is out of proportion to the actual threat. The fear, anxiety, or avoidance typically lasts for at least 6 months, causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, and should not be attributable to the physiological effects of a substance, another medical condition, or to the symptoms of another mental disorder. Social anxiety disorder has a negative effect on people's thoughts, which can center on themselves or can center on how others will react to them. It can also cause negative physical symptoms, which can be very troubling to people suffering from social anxiety disorder, who tend to be overly concerned about visible signs of their anxiety, such as blushing or sweating. Behaviors can also be negatively affected. If people with social anxiety disorder cannot avoid an anxiety-provoking situation, they will often adopt behaviors to protect themselves from scrutiny or embarrassment. For instance, they may avoid eye contact or conversation, or they may leave a party early. They may also use drugs or alcohol to temper their anxiety. Safety and concealment behaviors, like dressing in such a way as to mask sweating or wearing makeup to conceal blushing, are problematic because they can directly exacerbate anxious symptoms and prevent disconfirmation of the feared outcome, therefore maintaining heightened self-focused attention and drawing greater negative attention from others. Individuals with social anxiety disorder may be inadequately assertive, excessively submissive, or, less commonly, highly controlling of conversations. They may show overly rigid body posture, inadequate eye contact, or speak with an overly soft voice. They may live at home longer, delay marrying and having a family, or avoid certain jobs or the workforce altogether. Social anxiety disorder is associated with elevated rates of school dropout and with decreased well-being, employment, workplace productivity, socioeconomic status, and quality of life. It is furthermore associated with being single, unmarried, or divorced, and with not having children, particularly among men. Despite the pronounced distress and social impairment associated with the disorder, only about half of individuals in Western societies ever seek treatment, and they tend to do so only after 15 to 20 years of experiencing symptoms. Gerald was a 36-year-old accountant for a large trucking company who sought help for his social anxiety from Dr. Aaron Beck, who described Gerald's clinical presentation as being quite typical. Having suffered with social anxiety since childhood, Gerald reported feeling extreme anxiety in most social situations and was conscious of the degree to which this had negatively impacted his life. Consumed with an overwhelming fear of being noticed and judged, Gerald had never had an intimate relationship and reported having no close friends. Gerald's safety behaviors included working unconventional hours in order to avoid contact with others and avoiding any new situations or experiences, even though he recognized that these behaviors had severely limited his professional opportunities and his personal life. Wishing to improve his fitness level, Gerald joined a gym, but quit after a few months as attending caused him too much distress. Gerald was quoted as saying, "I'm tired of waiting for life to start. Sometimes I just want to get it over with." There are no clear-cut answers as to why some people develop social anxiety disorder, although research suggests that various factors are implicated. Like most mental health problems, social anxiety disorder appears to be caused by biological and psychological factors combined with challenging life experiences, such as traumatic life events, a family history of anxiety disorders, or other mental health or substance use problems. The DSM-5 lists temperamental risk factors, including behavioral inhibition and fear of negative evaluation, environmental risk factors such as childhood maltreatment and adversity, and also genetic and physiological risk factors. Social anxiety disorder is heritable, with first-degree relatives having a 2 to 6 times greater chance of having the disorder. Social anxiety disorder is often comorbid with other anxiety disorders, major depressive disorder, and substance use disorders, but the onset of social anxiety disorder generally precedes that of the others, except in instances of specific phobia or separation anxiety. Chronic social isolation experienced in the course of social anxiety disorder may result in major depressive disorder, particularly for older adults. Substances may be used as self-medication for social fears, but the symptoms of substance use, such as trembling, may prove to exacerbate those fears. Social anxiety disorder is frequently comorbid with bipolar disorder, body dysmorphic disorder, and also avoidant personality disorder. In children, comorbidities with high-functioning autism and selective mutism are common. The symptom presentation for social anxiety disorder may vary across cultures, even within Western countries. As such, it is important that diagnostic criteria must be considered in a cultural context. For instance, a fear of offending others may be the predominant fear in individuals from cultures with strong collectivistic orientations. While Asian samples have some of the lowest rates of social anxiety disorder, US and Russian samples have some of the highest. Found primarily in Japan and Korea, TKS is a culture-specific expression of social anxiety disorder involving concerns about offending or embarrassing the other person rather than embarrassing oneself. Social fears are culturally contextual. The same social behavior may be perceived as normal in one culture, but unreasonable or excessive in another. Key cultural mechanisms that influence social anxiety disorder include individualism versus collectivism, perception of social norms, and self-construal. Social anxiety disorder differs from normative shyness in that it has a significant adverse effect on social, occupational, and other important areas of functioning. The key feature of agoraphobia is a fear and avoidance of social situations because escape might be difficult or help unavailable, rather than a fear of negative evaluation. In panic disorder, the concern is focused on the panic attacks themselves, rather than on a fear of scrutiny. While social worries are common in generalized anxiety disorder, the focus is more on the nature of ongoing relationships rather than on fear of negative evaluation. Although individuals with separation anxiety disorder may avoid social situations that could separate them from their attachment figures, they're usually comfortable when their attachment figure is present or when they are at home, situations that may still trigger social anxiety disorder. Individuals with specific phobias may fear embarrassment or humiliation related to their phobia, but they do not generally fear negative evaluation in other social situations. Social phobia is closely related to simple phobia on account of the specificity of the fear. The COVID-19 pandemic has caused some unprecedented changes to how people work, play, and socialize, which, as anticipated, have had particular impacts on those suffering from social anxiety disorder. Research has shown that many individuals with social anxiety disorder who are gainfully employed are faring better than baseline. Changes brought about by various stages of the COVID-19 lockdown, such as working from home, restricted social activities, and fewer instances of social contacts generally, have brought relief from symptoms. With fewer distractions and less anxiety, individuals with social anxiety disorder have reported more productivity and greater feelings of self-efficacy. However, their typical anxieties have been replaced with a new anxiety, that being a fear of a return to the workplace and to the normal situations known to trigger their distress. The pandemic has also, interestingly, caused a shift in presentation of TKS, which is now being seen across cultures and is manifesting as anxieties related to causing distress in others on account of quarantine requirements related to contact tracing, or societal rejection based on fear of infection or COVID positivity.
Social anxiety disorders, SAD, can be treated using several approaches that include psychotherapy and pharmacology. In this presentation, we explore the use of CBT as a treatment option for social phobia. Our choice is based on well-established findings that support the efficacy of CBT for social phobia. Cognitive behavioral theories of SAD propose that distorted cognitions and safety behaviors are responsible for developing and maintaining SAD. As such, CBT aims to change distorted cognitions and dysfunctional safety behaviors by emphasizing a reduction in problematic behaviors and promoting more functional ones. We will therefore discuss 5 CBT treatment options that include emotional regulation, self-compassion and assertiveness, systemic exposure, mindfulness, and cognitive restructuring. The ability to control and modulate emotions when they come, how they are experienced, and how they are expressed, particularly in social settings, requires conscious monitoring. This is known as emotional regulation. Difficulties with emotional regulation have been found to develop and maintain psychopathologies like social anxiety disorder. Cognitive models of SAD state that individuals with poor emotional regulation believe that they have very little control over their emotional responses. As such, these individuals will experience 1. Emotional hyperactivity, as seen as in their persistent fears of negative evaluations, and 2, emotional dysregulation, as seen by their inability to control their fears. A case in point is the case of Gerald, who was not able to control his fears and engages in avoidance behaviors. It is worth noting that persistent difficulties in emotional regulation serve to develop and maintain SAD. If patients do not believe that they can influence their emotions, then deploying effective emotional regulatory strategies will not be possible. People with SAD struggle with many social and personal impairments, which make it hard for them to enjoy their lives fully and regulate their emotions well. Effective emotional regulation can therefore reduce emotional reactions to stressful and anxiety-provoking situations. Clinical treatments for emotional regulation take a cognitive approach that involves 1. Employing cognitive skills to modify emotional reactions, for example, reframing the meaning of thoughts and situations, or challenging interpretations, and 2. Enhancing the use of emotional regulation skills to modulate emotional reactivity. There are 5 strategies used to enhance emotional regulation, and for this we will take a look at the case of Gerald again. For situation selection, we could select the gym, which is an anxiety-provoking situation for him, and through this experience, reframe his interpretation so as to modify his emotional reactions. For situation modification, we could modify his odd working hours so as to help him diminish the emotional impact he feels while working normal hours. For response modulation, we would look at helping Gerald reduce his anxieties and how these are expressed. For attention deployment, directing Gerald's attention to environmental features in the office like potted plants or paintings could help him reduce his intense emotions of fear. When I worked as a designer in the past, we used such features to enhance the overall mood in the workplace. For cognitive change, Gerald's emotional responses to fear and anxiety could be modified as we challenge some of his cognitive thoughts around what people think about him. Who would have thought that self-compassion would have any correlation with social phobia? Well, the reality is studies have found that people with SAD have a negative and self-critical cognitive orientation. In fact, most of these people view their world from a lens that enhances negative self-judgment and, in most cases, shame. It is no wonder that these negative and self-critical states only serve to develop and maintain the disorder. But what is self-compassion? It is having an accepting and caring orientation towards oneself. It is being kind and understanding in times of pain and failure. It is perceiving one's experiences as part of a larger human experience, not an isolated case. It's not over-identifying with painful thoughts and feelings. In that regard, self-compassion enhancement has been found to be an effective treatment for people with SAD, showing positive results for reduction of symptoms like shame and irrational beliefs. How does self-compassion enhancement work as a treatment for SAD? It begins with cognitive appraisals, challenging irrational beliefs, negative thought patterns about self, and replacing this with kinder thoughts. It also involves the application of various self-compassion activities, including self-compassion writing exercises, which are in the form of written positive attributes about oneself done at least 3 times a week. Repeated compassionate self-statements, which include statements like, I am valuable, I make a difference in people's lives. This repeated several times a day helps to enhance self-compassion. Compassionate self-imagery involves imagining oneself in positive ways. For example, imagining oneself helping others in need and doing acts of kindness. The ability to express one's own interests, emotions, and thoughts, including standing up for oneself comfortably without any anxiety or violation of others' rights, is being assertive. It was Eleanor Roosevelt who said, "Nobody can make you feel inferior without your consent." People with SAD struggle with assertiveness, and to reverse that, assertive training has been proposed as a treatment option. This training takes a behavioral and cognitive approach aimed at 1. Enabling verbalization of needs and wants in life situations, 2. Reducing anxiety-based inhibitions, and 3. Building social skills for competent social functioning. This intervention has been found to show positive results for improved self-image, improved self-confidence, and better social influence. Systemic exposure as a treatment is also referred to as exposure therapy. The goal here is to systemically expose clients to their objects of fear with the hope that they will become desensitized enough to it and then change their avoidant behaviors. An example is the fear of dogs. One can be exposed to a service dog, encouraged to pet it until they are comfortable enough to be left alone with it. Therapy can be done in group or individual settings, out in the community, or in a clinic. Sessions are controlled by the therapist to ensure that the environment is safe for clients to move progressively to their fear stimulus without the fear of severe negative reactions. The use of CBT here applies cognitive techniques, exposure, and anxiety management techniques to address irrational fears and anxieties so as to encourage alternative ways of thinking, feeling, and behaving. Studies show that SAD can be treated well through the use of systemic exposure therapy. This is carried out in 4 main ways. Fieldwork exposure and virtual reality exposure are very similar, except that one is done out in the field while the other is done virtually through the use of technology. In both cases, however, the client is still exposed to the fear stimulus. In imaginal exposure, the client is exposed to the fear object or situation through vivid imagination. For example, a client can be asked to imagine giving a speech in public until they are confident enough to do it in a real setting. Lastly, interoceptive exposure involves deliberately bringing on physical sensations that are harmless, yet feared and associated with anxiety. For example, sweaty palms, which a client connects to anxiety, can be brought about by an unrelated stimulus, making the connection to anxiety bearable. Systemic exposure is introduced in gradual paces until the client is able to handle full exposure, overcoming their fears. Starting with grading, the therapist helps the client list down their fears in hierarchical terms, then begins exposure from the mild ones, progressing up to the most difficult ones. In flooding, the client is encouraged to start with the most difficult fears in their hierarchy, not a soft landing here. In systemic desensitization, exposure is combined with relaxation exercises, making the experience more manageable for the client. Exposure therapy has shown many positive benefits, including self-efficacy, where one regains the capacity to confront their fears and manage anxious feelings. Nelson Mandela, the former president of South Africa, is quoted as saying, "I learned that courage was not the absence of fear, but the triumph over it. The brave man is not he who does not feel afraid, but he who conquers that fear."
Cognitive restructuring is based on the idea that people with social anxiety have maladaptive core beliefs that create interpretative biases, similarly to wearing colored lens eyeglasses. These biases influence their perception of the world, interpretation of social situations, and anticipation of the future. Maladaptive core beliefs impact individuals' automatic thoughts, which in turn impact their feelings, which cause them to engage in safety behaviors, which then reinforce their irrational core beliefs and negative automatic thoughts, creating a vicious cycle. Dr. Beck explains that one of the primary objectives of cognitive therapy for social phobia is reducing anxiety and eliminating feelings of embarrassment, anticipation of rejection, and negative evaluation by others. It involves challenging individuals' thoughts so they become more helpful and realistic by correcting their faulty appraisals and beliefs of social threat and personal vulnerability. Cognitive restructuring is a therapeutic process that draws on different methods aimed at helping the person to identify, challenge, and then modify their irrational core beliefs and automatic thoughts that cause and reinforce social anxiety. The first step involves helping clients discover their automatic thoughts and irrational beliefs. Dr. Beck suggests using a diagnostic interview, self-report questionnaires, downward arrow technique, or enhanced recall through imagery. The second step in cognitive restructuring involves challenging irrational core beliefs. Socratic questioning can be used to examine the facts and evidence supporting one's beliefs with the goal of providing contradicting evidence to challenge them. Other techniques that could be used are reverse role play, decentering, and re-evaluation of pros and cons of holding on to irrational beliefs. And finally, the last step in cognitive restructuring for social phobia is modifying maladaptive core beliefs and replacing them with logical and rational thoughts. This can be done by correction of exaggerated interpretations, which is often done by observing others in feared situations, and examining evidence, evaluating alternatives, and by using video feedback technique. Mary suffers from social phobia. She came to treatment due to extreme panic in situations like writing in front of others or one-on-one meetings. Mary's dysfunctional core beliefs were discovered with the help of self-monitoring. And like many people with social phobia, Mary's thoughts about her performance in public were characterized by dysfunctional beliefs about the way she should behave. To challenge her fears of being humiliated and thought of as silly by others in situations like, for example, paying for her groceries, Mary was asked to provide evidence for knowing what other people might be thinking of her. By looking at other people, Mary realized that she has no evidence of what their thoughts at the moment were. Then, to modify her beliefs, Mary was asked to track her irrational cognitions and identify alternatives while observing the behavior of others. So Mary went grocery shopping with her mom. And while her mom was paying for the groceries, Mary was observing her and other people. And Mary realized that no one was actually paying attention to her mom, and people were just minding their own business. Then Mary accepted the idea that even if other people thought she was silly, it really didn't matter to her. The core elements of mindfulness-based approach to social anxiety involve training attention and cultivating mindfulness, the skill of intentionally focusing on the experience in the present moment without judging. While CBT aims to challenge and restructure individuals' irrational beliefs, mindfulness-based approach aims to decenter clients' attention by teaching them to recognize the presence of anxiety-causing thoughts and treat them as just thoughts without following them or reacting. Mindfulness increases selective attention, which helps people remain focused on the person in front of them and take genuine interest in conversation while treating their anxiety-related discomfort as a background noise which does not deserve their attention. People who practice mindfulness become more aware of their physical sensations and feelings and can identify harmful thought patterns and disengage from them before they become a threat, which is called thought diffusion. Mindfulness-based cognitive therapy was initially developed by Drs. Segal, Williams, and Tisdale in 2002 to reduce relapse in depression. Over the past 10 years, it gained popularity and found wider applications to treat different mood disorders. MBCT employs a number of techniques and exercises, such as breathing exercises, body scan meditation, mindful stretching, mindful walking, and self-compassion. MBCT targets social phobia by enabling people to interrupt automatic thoughts that trigger anxiety by teaching them to recognize the presence of negative thoughts and associated body sensations that occur together with the episode of social phobia. Once someone recognizes that they are experiencing negative thoughts, instead of following them, they make a conscious effort to let go of those thoughts by understanding that they are irrational and unrealistic and view them from a decentered perspective. Let's go back to Gerald. When Gerald faces socially feared situations, he gets hot and flushed and believes that people can notice that and think that something is wrong with him. When he learns to practice mindfulness, Gerald will be able to recognize that sensations in his body, such as heat, sweat, palpitations, and shallow breathing, are merely the signs of social phobia. He will learn not to follow the thoughts related to what others might think of him, and treat his discomfort just as a background noise, which will not prevent Gerald from being engaged in the present moment and focused on the person in front of him. Research has found that mindfulness changes anxiety-related brain structures and helps people regulate their thinking patterns. Mindfulness-based interventions for individuals with social anxiety resulted in better social adjustment, increased self-compassion, and overall better functioning. Social anxiety treatment focuses on targeting the disorder at its three stages: anticipatory stage, during the exposure, and post-event. Every stage of social anxiety is associated with specific automatic thoughts and their impact on individuals' feelings and behaviors. For example, at the anticipatory phase, socially anxious individuals perceive themselves as vulnerable and incapable of meeting their perceived social performance standards. During the exposure to feared situations, maladaptive core beliefs of threat and vulnerability result in creating attentional bias for threat and lead to increased focus on cues for anxiety. During the post-event stage, individuals engage in detailed recall and reevaluation of their performance, and they are actually likely to conclude that their performance was much more negative than was actually the case, and this plays a vital role in maintenance of their social anxiety. Dr. Beck explains that in order to achieve durable relief from a mental disorder like social anxiety, individuals' dysfunctional core beliefs that contribute to anxiety-causing automatic thoughts and behaviors need to be challenged, and this can be done in the process of cognitive restructuring. Selection of the best treatment method depends on many factors, such as client's learning style, the nature of the problem, and the therapist's knowledge and expertise. Challenging an individual's maladaptive core beliefs and replacing them with healthy and more adaptive ones in the process of cognitive restructuring is the goal of the treatment, which leads to durable and long-lasting results. Research has proven that cognitive restructuring and automatic thought challenging is among the most effective CBT approaches. Moreover, their effects are amplified when used in combination with another technique, such as exposure therapy, mindfulness, assertiveness, or social skills training. It is important to note that every technique has its limitations, and there is no one-size-fits-all solution. Properly matching the technique with the client is essential to achieving the best treatment outcomes. Dr. Beck explains that social phobia responds very well to CBT treatment. Cognitive behavior therapy for social phobia aims to reduce social anxiety and avoidance behaviors by correcting faulty social threat attention and interpretation biases, eliminating reliance on safety strategies, increasing tolerance to discomfort, and decreasing post-event rumination. Research findings suggest that cognitive therapy that includes cognitive restructuring and exposure to feared situations produces clinically significant and long-lasting improvement in 75% of individuals who complete the treatment. Thank you very much for watching this presentation. We hope you enjoyed it.